Bismillah ar-Rahman ar-Rahim. Assalamu alaikum, everyone. Good afternoon. My name is Dr. Amal. I'm a metabolic genetics consultant here in Abu Dhabi at Sheikh Khalifa Medical City. And it's a real honor for me to be among this group today to present a topic that is maybe a different topic compared to what you've been hearing today. So I'll talk about the unusual causes of hepatosplenomegaly. And when we deal with rare diseases, it's always important to set the stage with cases. So I'll present the first case. He's a 16-month-old male referred to the general pediatrics clinic. And the reason for the referral is basically abdominal distension that is caused and confirmed by physical examination to be due to organomegaly. When obtaining further history, this child is significantly not growing well, so there is significant failure to thrive. There's also easy bruising with minor falls. Otherwise, he's developmentally normal with appropriate milestones. And in terms of family history, he's the first child for parents who are first-degree cousins. When you examine this child, you find that he is non-dysmorphic. He looks pale, not jaundiced. His abdomen is significantly distended, and you confirm the hepatosplenomegaly with a liver of 6 centimeters below the costal margin and spleen of 11 centimeters down to the pelvis. On skin exam, you appreciate the bruises at different ages, and you confirm that he has a normal musculoskeletal and neurological examination. So how do you approach hepatomegaly in the context of a metabolic differential diagnosis? When we think of hepatomegaly, we can categorize the patient into 4 different categories. Hepatomegaly related to recurrent hypoglycemia, that related to cholestatic jaundice, mainly presenting with liver failure, or the group of hepatosplenomegaly with the presence or absence of storage signs, which I will maybe touch on later on. So if we look on the differential diagnosis further, recurrent hypoglycemia, we will think mainly of glycogen storage disease, type 1 and type 3. Those presenting with cholestatic picture and jaundice, the differential diagnosis will be including Niemann-Pick type C, alpha-1 antitrypsin, bile synthesis defects, and LCHAT deficiency and other fatty acid oxidation disorders. If the child presents with a picture mainly of liver dysfunction and liver failure, on the top of the differential is galactosemia and hepatorenal tyrosinemia, in addition to mitochondrial depletion. The first 2, of course, are treatable etiologies which need to be excluded. And unfortunately, mitochondrial depletion, we can only support the child with not much in terms of management. The last group, hepatosplenomegaly with a storage sign, includes the big group of lysosomal storage disease. So a well-known mechanism by which inborn errors of metabolism can lead to hepatomegaly is due to storage disease, basically buildup of accumulated material, which can be glycogen, neutral lipids, or complex lipids. And in order for us to approach the patient, you have to look at the consistency of the liver, and this sometimes can guide you, ultrasound findings, and most importantly, the clinical context. So if you have a child with hepatosplenomegaly, please look for coarse facial features, presence or absence of dysostosis multiplex, any sign of neurological involvement or regression, especially, failure to thrive, any other GI signs, presence or absence on, of course, investigations of inflammatory, immunological, or hematological signs, and lastly, if the child has recurrent hypoglycemia. So this will greatly help you to categorize your patient and hopefully reach the right diagnosis. So moving on to lysosomal storage diseases, as I said, these are the large group of rare inherited metabolic disorders. They are characterized by the pathological buildup of undegraded storage material in the lysosome, and this accumulation will lead to cellular dysfunction and the multi-system involvement that is usually seen in these patients. These disorders are very progressive, so over time, the patient will deteriorate. The overall incidence is estimated to be 1 in 5 to 8,000 live births, and they are a large group with more than 50 disorders identified. In general, there are no approved therapies for the majority of the lysosomal storage diseases. However, the number of treatable conditions is significantly increasing, especially in the last few years with the advent of new therapies. So again, the differential diagnosis of hepatosplenomegaly with presenting mainly with storage features, and these include coarse facial features, macroglossia, dysostosis multiplex, and vacuolated lymphocytes on the blood smear. And a differential diagnosis, if you find these features, include GM1 gangliosidosis, Niemann-Pick disease type A, eye cell disease, MPS type 7, galactosialidosis, and sialidosis type 2, which are very rare. Moving on to the differential diagnosis of hepatosplenomegaly in terms of metabolic diseases, mainly presenting with hematological features. So if the child has hepatosplenomegaly and found to have significant anemia and thrombocytopenia, Gaucher disease is among the top differentials that needs to be excluded. However, if the child presents with an inflammatory syndrome, so there's a macrophage activation syndrome with high ferritin, high LDH, also the presence of leukopenia, significant growth failure, protein aversion, and respiratory disease, you need to think of lysinuric protein intolerance. If the child has recurrent fever, please think of the mevalonic aciduria, which can be easily diagnosed by doing a screening urine organic acid. And transaldolase deficiency is an entity on its own, so it's a very unique inborn error of metabolism that presents with a facial dysmorphism, cutis laxa, hypertrichosis, sometimes hydrops fetalis that resolves with time, hepatosplenomegaly, hepatic dysfunction, in addition to anemia, thrombocytopenia, and multi-system involvement with renal and also cardiac abnormalities. And at SKMC, we have a few patients with this disease who have been managed with our GI colleagues here. So moving on to our patient case. So this is just a recap of what I just previously presented. So what are the next steps? So you do a CBC and you find a hemoglobin of 78, that is normocytic, normochromic, and platelets are also low at 54. So at this stage, you think of Gaucher disease, correct? So significant hepatosplenomegaly, especially if the spleen is larger than the liver, in addition to bruising secondary to thrombocytopenia and pallor due to anemia. So in order for you to investigate if this child has Gaucher disease, you will need to send a dried blood spot that is a screening tool that is easily accessible for all pediatricians. In general, is the beta-glucosidase enzyme. So when you measure the beta-glucosidase enzyme, the result comes back 1.4, which is way below the normal of above 2.5. So this child has a deficiency of beta-glucosidase enzyme. And then you proceed with your gene testing. So you ask for GBA gene sequencing, and you find that this child has a homozygous pathogenic variant that is confirming the diagnosis of Gaucher disease. And in addition, you can compound your diagnosis by adding or sending a biomarker, which is the glycosylsphingosine, in short, lyso-GB1. And in Gaucher disease, this is always elevated. So what is Gaucher disease? Gaucher disease is an autosomal recessive lysosomal storage disease that develops as a consequence initially of a GBA mutation, which results in deficiency of the activity of the lysosomal enzyme beta-glucosidase. And when we say autosomal recessive inheritance, you need both parents to be heterozygous carriers. In this case, they will have a 25% chance of having a child in each pregnancy that may be affected with this condition. If one of the parents is affected and the other one is a carrier, the risk of having an affected child is 50%. In terms of the gene mutations related to GBA, there are more than 300 mutations described. However, only 4 of these mutations account for 80 to 90% of cases, especially in the population of the Ashkenazi Jewish patients, and 50 to 60% of mutations outside this population. And the 344P is one of the most common mutations that we see here, especially in the Middle East. So what are the clinical features? The clinical features result from a deficiency of the enzyme acid beta-glucosidase. So you will have a deficiency of the conversion or the breakdown of glucosylceramide to glucose and ceramide, and therefore the buildup of glucosylceramide in the lysosome of the macrophages will lead to all of the manifestations in the spleen, liver, and bone marrow, thus resulting in hepatosplenomegaly, anemia, and thrombocytopenia. They will also accumulate in the brain and osteoclast, leading to neurological features in the type 2 and type 3 Gaucher disease, in addition to pulmonary complications. So Gaucher disease phenotypes are manifested as 3 major pan-ethnic types. So I'm sure all of you would know the most common type of Gaucher disease is type 1, which is the non-neuronopathic. So these patients mainly present with the visceral and hematological manifestations. Usually they do not have any neurological features. They can present from childhood to adulthood, and their lifespan is usually also very long if they are treated properly. The type 2 is the most severe and the most devastating. So it's called the acute neuronopathic. These patients usually present in early infancy. They have massive hepatosplenomegaly, anemia, thrombocytopenia with significant neurological manifestations. They have a dystonia, significant failure to thrive, and usually they do not survive beyond their first or second birthday. And this type is untreatable, so the enzyme replacement therapy does not cross the blood-brain barrier. Type 3 chronic neuronopathic is also a common phenotype that we see here in the Middle East, especially in the UAE. So these patients have a combination of the visceral hematological manifestations found in type 1. In addition, they have some chronic neurologic manifestations as well. And they may initially present with oculomotor apraxia, ophthalmoplegia, and then they can progress to have myoclonic epilepsy. And unfortunately, over time, they will develop further neurological manifestations. So Gaucher disease is associated with significant phenotypic heterogeneity. So I know that I just presented type 1, type 2, and type 3, but in real life, the patient doesn't come to you and tell you that I'm type 1 or type 3. Sometimes it's very difficult to differentiate between these two. And as you can see here, the spectrum of clinical manifestations is very variable, and the patient can present anywhere on the spectrum. Gaucher disease type 1, as I already mentioned, is a multisystemic disorder, which is characteristic for all of the lysosomal storage diseases with, as I mentioned, also heterogeneity. So there is a difference between the adult and the children who present with Gaucher disease. And the key difference is that in pediatric age group, typically the disease is more aggressive with worse severity compared to the adults. And because it's more progressive, of course, it leads to more severe complications, especially on the bone. So the accurate diagnosis, again, is based on a thorough clinical history and physical examination. And as I mentioned, if you have the suspicion, please just order the test and exclude the disease rather than kind of missing the diagnosis, because this is a treatable condition. So patients with suspected Gaucher disease should undergo a comprehensive initial assessment, which of course, as I mentioned, includes the enzyme assay, confirming the GBA deficiency, family history and genotyping. So when you identify an index, you will screen the siblings and the rest of the family, do a thorough physical examination to assess the severity of the disease, the rate of progression, and predict the response to therapy. Lab evaluation is critical, so you need to do a baseline CBC and biomarkers, visceromegaly evaluation with an ultrasound, and of course, don't forget the quality of life, and because this is a chronic disease, so it has significant psychosocial impact. So manifestations occur usually during childhood. However, the diagnostic steps are quite different from those in adults. So in any child who presents with splenomegaly, even without the presence of hepatomegaly, but in the presence of both, of course, you need to look for thrombocytopenia and anemia. If you find these are both positive, you have to assess the presence of growth deceleration, do an X-ray to look for the bone manifestations, look for the CNS features, which are the oculomotor apraxia. If these are present, you have to send, of course, the enzyme assay. And of course, if it's positive or confirming the enzyme deficiency, you have a diagnosis of Gaucher disease.
Enzyme replacement therapies
So the
share a
treatment.
similar mode of
Enzyme
action.
replacement therapy has been the
Firstly,
cornerstone
the
for
presence
treatment
of
in
modified
patients
mannose
with
sugars
Gaucher
allows
disease. So it's the first
internalization
line
by the
gold
macrophages.
standard for treatment in Gaucher
Secondly,
disease.
the
So
deficient
basically,
GBA
enzyme
activity
replacement
is
therapy
replaced with
works
the
at
enzyme replacement
modification of
therapy,
the
leading
mannose
to improved
sugars, which are at
hydrolysis
the
of
lysosome
glucosylceramide. This
membrane
corrects the
to target
initial
the macrophages and
pathophysiology of
get
Gaucher
internalized
disease,
into the
preventing
lysosome. When
secondary
the enzyme goes
pathology.
into the lysosome, it corrects the deficiency of the enzyme and works to hydrolyze or break down the accumulating compound, which is in this case glucosylceramide. And as a result, it reduces and helps to reverse the secondary pathology that is seen in this condition. So let's go back to our patient with Gaucher disease. So he was started on enzyme replacement therapy with amiglucerase at the maximum dose of 60 units per kilo every 2 weeks. He had no infusion-related reactions, and he continues to receive therapy in the day infusion clinic. He was, of course, referred to the dietitian to improve his growth and weight. And he continues to follow with ophthalmology and cardiology to screen him annually for possible complications. So he has stable hemoglobin and platelets. He has a significant reduction in his biomarker, which is a good tool to assess the response to therapy, improved growth, and resolved organomegaly. And as you can see here in the picture, before and 1 year after treatment. So the abdominal distension and the organomegaly completely resolved. So in conclusion, early diagnosis and treatment of Gaucher disease is essential to prevent and reverse severe disease-related complications. Splenomegaly and thrombocytopenia are the most prevalent symptoms in this disease. Gaucher disease can be diagnosed or ruled out by a simple dried blood spot enzymatic assay for acid beta-glucosidase. The combination of an algorithm and the enzyme activity can help to achieve earlier diagnosis of Gaucher disease. And always when things don't fit, think outside the box. So moving on to the second patient case. So this child is a 4-year-old male who was referred in addition to the pediatric clinic with the same reason for referral, abdominal distension due to organomegaly. This child, however, had a different history and slightly different history from the first patient. So he had failure to thrive, but he also had significant recurrent chest infections. And when you take the developmental history, you find that this child is significantly delayed. The family history, again, parents are first cousins. On examination, you confirm the hepatosplenomegaly. And at that point, normal musculoskeletal and neurological examination. But again, the only difference here, recurrent chest infections and delayed developmental milestones. So what are the next steps in this case? So you send the patient in the presence of neurological features. You need to think of CNS-related lysosomal storage diseases. So you think of the GM1 gangliosidosis, Niemann-Pick disease, etc. So in order for you it will help you in your differential diagnosis, you need to do an eye examination. So the ophthalmologist can help you to look for cherry red spot. So in this case, there was a suspicion, but the ophthalmologist couldn't confirm that this is a clear cherry red spot. Pulmonary review, the pulmonologist reports that there is evidence of interstitial lung disease. And then you suspect the diagnosis, which is the sphingomyelinase deficiency. So you send the enzyme sphingomyelinase and you confirm that it's low. And subsequently, you send the gene related to this condition, SMPD1, and you confirm that this child has acid sphingomyelinase deficiency. So what is acid sphingomyelinase deficiency, or ASMD? This is also a rare, progressive, and often fatal lysosomal storage disease. And previously, it was considered untreatable. However, during the past year, there is a new therapy for this condition, and that's why we have to be more aware in order to pick up these patients. So again, it's an autosomal recessive lysosomal storage disease. Mutations in the SMPD1 gene will lead to deficiency of acid sphingomyelinase enzyme, and this will lead to accumulation of sphingomyelin. This will damage organs, commonly the spleen, liver, lungs, and hematological system, with involvement of the CNS in some patients. And it leads to significant reduced life expectancy and potentially neurological decline in the acute forms. So this is an example or a picture of a child who has a chronic systemic ASMD. Historically, ASMD deficiency was called Niemann-Pick disease type A and B. Why do we exclude type C here? Because Niemann-Pick type C has a totally different genetic, pathologic, and prognostic aspect. ASMD is often confused with Gaucher disease because there are a lot of similarities. And I list here all of the features that can be commonly found in both conditions. So hepatosplenomegaly, anemia, thrombocytopenia, bleeding and bruising, fatigue, bone pain, growth retardation, and also dyslipidemia. However, the major differences is that ASMD can, in addition to these features, present with progressive or significant lung disease in addition to cirrhosis. So ASMD and sphingomyelin accumulation. So what's the pathophysiology? Sphingomyelin is an essential component of the cell membrane. It's involved in the critical cellular signaling processes through generation of ceramide. So in the normal process, you have the breakdown of sphingomyelin to phosphocholine and ceramide, and this is the normal sphingomyelin metabolism. However, in ASMD, because of the deficiency of the enzyme, the sphingomyelin will not be converted into the precursor, the products, and therefore the accumulation of the sphingomyelin will lead to the multisystemic involvement and the substantial organ damage. And again, it's found in the macrophages of the liver, spleen, lung, and bone marrow. And in the severe cases, especially the acute type A, in the neurons, and can present with significant neurologic manifestations. So again, in ASMD, there is a spectrum with 3 overlapping subtypes. Type A, which is the rapidly progressive form with multi-organ and neurologic symptoms. Usually they present very early in life, and they have a short life expectancy of maximum around 2 to 3 years. And they usually die because of respiratory failure and multi-system failure. On the way far end of the spectrum is type B, which is the most prevalent. It's the chronic multi-organ disease manifestations with no neurologic involvement. And this form presents also as early as infancy and can present as far ahead as in adulthood. The life expectancy is typically from the 2nd to the 7th decade of life. And the leading cause of death is also respiratory disease, liver disease, and bleeding. In between the type A and type B is the type AB, which is the intermediate form. It also has the multi-organ involvement, but variable degree of neurologic involvement. So progressive sphingomyelin accumulation results in multi-organ involvement. More than 90% have splenomegaly, more than 80% have interstitial lung disease, more than 70% have hepatomegaly. Thrombocytopenia is seen in 50% of patients, musculoskeletal symptoms in up to 75%, and dyslipidemia in more than 70% of patients. So how do you diagnose ASMD? So based on the clinical suspicion from the history, physical examination, and initial simple blood tests, you will have the suspicion, and based on that, you can order your enzyme activity. So ASMD enzyme activity can be measured on the dried blood spot, leukocyte, fibroblasts, etc. And then, of course, if you have a deficient enzyme, you can proceed to confirm with genetic testing. In ASMD, we also have biomarkers, and in this case, it's the lysosphingomyelin level, which are positively associated with the clinical severity in this disease. So the treatment, and this is the exciting part. So the olipidase alpha is the new enzyme replacement therapy for the treatment of ASMD. Similar to the enzyme replacement therapy in other lysosomal storage diseases, it basically replaces the defective or deficient enzyme, allowing for the normal breakdown, in this case of sphingomyelin. So the indication of olipidase alpha is the long-term enzyme replacement therapy for treatment of the non-CNS manifestations of ASMD in the pediatric and adult patients. So ideally, the patient has to have type B and sometimes type AB. However, type A patients with significant neurologic features, usually this treatment will not work because it doesn't cross the blood-brain barrier. So olipidase alpha in patients with ASMD type AB or type B. So these are the clinical trial results, which are presented here. Ascend the PEDS and the extension study. So you can see the improvement in the spleen, lung volumes, liver volumes, growth, biomarkers, and also the respiratory markers. So in summary, ASMD is a rare genetic progressive lysosomal storage disease with a broad phenotypic spectrum caused by pathogenic variant in the SMPD1 gene, which encodes the sphingomyelinase enzyme. Progressive accumulation of the sphingomyelin will lead to deficient ASM enzyme activity, resulting in multi-organ involvement. Clinical manifestations typically include pulmonary impairment with interstitial lung disease, hepatosplenomegaly, thrombocytopenia, dyslipidemia, restricted growth, and osteoporosis with bone marrow abnormalities. The liver and respiratory complications are the leading cause of death in patients with ASMD. And in clinical trials, treatment was proven to be effective with olipudase alpha, resulting in improvement in the clinical relevant outcomes in children and adults with ASMD types B and types AB. And this is the end of my talk. Thank you very much.